So sites, okay. Okay, so you should know the sites that have normal flora, and that for you as medical doctors is something that's quite important. You should also know sites that do not have normal flora. And again, that is very important in terms of your laboratory test interpretation. And I'll talk about that towards the end. The advantages and disadvantages of the normal flora, and with new technology methods that are used for restoring the good flora once it's been eliminated from the system. So what is the normal flora? This is a mixture of microorganisms or bacteria, mainly bacteria and fungi, that are found in different parts of the body. And this is specifically in normal, healthy individuals. Once you get sick, that sort of changes. Now, we know we have about 10 to the power of 13 body cells. And what has been found is that there are more microorganisms than body cells. So about 10 to the 14 of microorganisms. And this is mainly bacteria and fungi. There are individuals who say that viruses form part of the normal flora, but again, some people tend to not agree with that. And so parasites and viruses are not broadly classified as part of the normal flora. Now, the normal flora itself varies with the sites of the body. You'll find 10 to the power 5 to 6 on the scalp. The largest amounts being in the gut, and that is probably one of the most widely studied normal flora in the body, and with the largest amount again towards the descending colon, getting into the rectum, and so getting into the feces. But we'll go again side by side. So there are several groups of normal flora, broadly classified into two: the resident flora and the transient flora, but I'll add a third one. So resident flora is bacteria or fungi that are known to have an established niche at a body site that they tend to occupy indefinitely. So they are, unless something changes, they are there all the time. They do not cause disease at that site. And if for any reason something displaces them or causes a change, they tend to reestablish themselves. They are quite broad. And again, as I said, they differ by site. So in the upper respiratory tract, and again, we'll go step by step on this. So you'll find what is in the upper respiratory tract will also differ depending on the part of the upper respiratory tract you are at. So if you're in the mouth, that might be different from what's in the nasopharynx, what's in the lungs. So it differs by site. In the GIT as well, differs from what's in the esophagus, from what's in the stomach, from what's in the different parts of small intestines and in the large intestines. And then we have, of course, in the genital tract. So we'll go again step by step on that. Then we have the transient flora, and this comprises both bacteria that cause disease and bacteria that do not cause disease normally. And they are found at a site, and based on what the name is, it's transient. So they are only there for a limited duration of time. And that varies. That could be hours, that could be days, that could be months. And they're usually acquired from the environment. The body tends to clear them. They can, if they're on the skin, they can actually be cleared mechanically. And that's by rubbing, unlike the resident flora, which cannot be cleared mechanically. But on top of it, flora can also be cleared by competing with the resident flora. So the resident flora tends to occupy the niche, so it excludes the transient flora, and the host immune response can also clear transient flora. But it is known to have the ability to colonize, multiply within a site, and when it does that, it causes opportunistic infections. But that's only possible if the resident flora is not intact. So once you interfere with the resident flora, then the transient flora is then able to cause opportunistic infections. The third one is the carrier state, and this is a condition in which a person carries. So it comes from a person carries a potentially pathogenic infectious agent without causing any visible clinical disease. And this, I think, the most commonly described case is the typhoid Mary, a lady who was carrying the typhoid bacteria, that's Salmonella typhi, but was not showing any symptoms of disease, but managed to spread bacteria to many people and cause infections. So that's just the third state. You may find it in books, you may not find it in books, but it's good to have just an idea that it's one of the potential groups of pneumoflora. So where does it come from? Newborns, as long as they're in utero, are sterile. They do not have any bacteria on them. But then as they move down the vaginal tract during delivery, they get exposed to, or they rub against bacteria. They can also inhale bacteria or even swallow. Like, for example, if there's meconium, they can swallow that and then sort of establish normal flora within their system. So there are several sites or sources of normal flora thereafter, that's after delivery. One of them is the GIT tract, which could be depending on what they are feeding on or even what they're exposed to. The urogenital tract, either migration from this normal flora of the skin and normal flora of the lower GI tract, the vaginal birth canal, as we said, and the environmental sources as well. There is the oral nasopharyngeal cavity that's based on what they eat, migration from the skin, environmental as well, and the skin itself, based as they track down the vaginal tract, they are acquiring normal flora on their skin and also from environmental sources. And that the amount of bacteria tends to increase over time. So in utero, they don't have any. As they get through the system and at birth, they tend to acquire, depending on the mode of delivery, also on the gestational age. At infancy, we're talking about feeding, is it breast milk versus formula, where geographical has been shown to have an effect on the kind of normal from flora profile an infant has, their family members, the interactions with other people or interactions with the environment, the maternal diet and weaning has also been shown to contribute to it. And that amount of normal flora increases as they go from birth to childhood, and we'll talk about even to the elderly. There are shifts in the profile of the normal flora. So by site, now we're not able to cover the entire body. So what I'll do, and I think most of these bacteria might still be Greek to you, with time you'll become very professional in them. So I'll just mention a few so that there's not much confusion, just the most important at this point. So the skin. I think in anatomy, we're always told that the skin is the largest organ of the body. And surprisingly, it doesn't, it also has quite a large amount of microorganisms on it, 10 to the power 3 to 10 to the power 4 organisms per centimeter squared. These are mainly found not on the surface, the slightly deeper layers in the stratum corneum, in the deeper part of the stratum corneum. They're also found in the hair follicles, and the purpose of the normal flora in the hair follicles is to act as a reservoir. So basically, if you replace what's on the top, then it acts as a feeding mechanisms, like adding or releasing a fresh supply of normal flora. We also have normal flora in the deeper follicles, and that because the oxygen supply at that level is not as good as on the surface, they tend to be what are known as anaerobes. I believe you've done the classification of bacteria. So have you done that? Do you know what anaerobes are?
Yes.
Yes, okay, yeah. So these tend to be anaerobes, again, because of the poor supply of oxygen at this site. So the most important microorganisms in terms of the skin is the Staphylococcus epidermidis. That's the most common. And again, once you do staph, you'll understand why it is the most important. But then we also have Staphylococcus aureus, which also tends to be very important for clinical purposes. We have Corynebacteria, different types of streptococci, which I think we're talking about in a week's time or thereabouts. The anaerobes, the peptostreptococci, which again we'll talk about next week, I believe. And then the yeasts, and this is mainly of the Candida species. And the Candida species is something you'll see very commonly, even clinically, with it moving from being a normal flora, particularly to causing disease. But we'll talk about that when we get to yeasts. But then there are factors that the body, also mechanisms that the body brings about to sort of limit the non-resident microorganisms coming and occupying a place and causing infection. The skin tends to be relatively dry, which is not very conducive to survival of most organisms. Tends to have an acidic pH, which would kill most of the bacteria that are not able to survive in acidic pH. There's also production of lysozymes that are produced by sweat glands, and this will cause breakdown or lysis of the cell wall. Our skin also tends to have a high sodium chloride concentration, again, not conducive for most bacteria that are not resident on the skin. And then this production of fatty acids, and this is from the sebaceous secretions. So these factors are basically there to make sure that what is normally found on the skin is what stays there and discourage colonization by non-resident microorganisms. What is good about having normal flora on the skin? It prevents the growth of fungi, and this is mainly the yeast infection or fungal infections. And this is because the bacteria will occupy or attach to a receptor, which I'll talk to sort of explain later, as an advantage that it attaches to receptors on the surface, and that prevents the transient bacteria from coming and attaching to the same receptors to cause infection. So preventing athlete's foot, for example. The bodies, some of the normal flora are known to cause disease or other features such as acne, which is produced by Propionibacterium acnes. Body odor tends to commonly be due to, well, apart from those who don't take regular baths, but that might also be because they don't get rid of the bacteria. Body odor is associated with, it's a negative feature of skin flora. And then we have possible opportunistic infections, and this is mainly by transient bacteria when, as I said, the resident bacteria are sort of cleared or displaced from their normal site. We have the conjunctiva, which has low numbers of normal flora, and these are usually coming from the skin flora. The main ones are Moraxella species. We have the diphtheroids, again, Staph epidermidis comes up, and then we also have the non-hemolytic streptococci. Colonization by non-resident bacteria is limited by the production of lysozymes that's found in lacrimal secretions. There's also flushing by tears, but there's apart from flushing, there's also the blinking that mechanically also removes bacteria from the type.
Dryness, hypertonicity.
If you can mute yourself, I'd appreciate, please. So the upper respiratory tract, again, this would sort of differ by site. We have the anterior nares, that's the nose, which tends to be, the normal flora tends to be similar to that found on the skin. The nasopharynx will tend to be similar to that found in the mouth. And the trachea and the lungs tend to be almost sterile. You want them as sterile as possible because they're much deeper, so the possibility of anything settling there causing infection is much higher. So with the nose, the most common is Staph aureus. Less common, Staph epidermidis comes up again, Corynebacteria, and different types of streptococci. And we'll talk about the streps next week. Then we have the oropharynx, which has this very dense streptococci, including strep mutans, which I'll talk about in regards to the tip. And then less commonly, different classes of streptococci, the non-pathogenic Neisseria, and Haemophilus influenzae, the non-typable strains. In the upper respiratory tract, protection against the non-resident flora is achieved through movement of the cilia. Is the flow of the mucus that's produced by ciliated cells, the lysozymes within the mucus, and then this phagocytosis by macrophages. And this, I believe, will be covered in some of them will be covered in immunology. The oral cavity, sterile at birth, but tends to be rapidly colonized by the organisms such as the facultative anaerobes and the aerobes. With the teeth, the strep mutants tend to be an important microorganism because they've been associated with position of dental caries. And then we have the gingival crevice, which is mainly colonized or inhabited by the anaerobes and the yeasts. Saliva has about 10 to the power 8 microorganisms per. So this, the oral cavity tends to be favorable for growth of bacteria, mainly because it's moist all the time, mainly because of this. But at the same time, you also have presence of food particles, and the food particles will then act as nutrients or surfaces on which the bacteria can settle on and multiply and cause potential infection, but also form what is known as biofilms. And biofilms is basically bacteria forming or settling on a layer and forming different layers on a surface. And these tend to be very hard to get or to reach, especially with antibiotics, and therefore very difficult to clear. And this can happen on plaque, can happen even in the surfaces of the dental caries. But bacterial growth is limited by the discommission of the epithelial cells, which is basically a mechanical flushing mechanism. And then there's a flow of saliva, which is basically washing away the bacteria and not allowing them to settle up on any of the surfaces. So what is the bad in terms of the oral cavity normal flora? We said strep mutans is associated with plaque formation and dental caries. And what happens particularly with the dental aspects of it is that during some procedures, for example, tooth extraction, you can have dislocation or introduction of the normal flora into the bloodstream. And this becomes important for patients who have any heart valve condition, whether they're deformed or whether they have prosthetic heart valves. So the bacteria would then settle on the heart valves and multiply and cause endocarditis. And therefore, it's very important, for example, if someone is undergoing a dental procedure, to know whether they have a heart condition, and especially heart valve disease, because in that case, then they need to get antibiotics prior to the procedure. For patients or for individuals, for example, who are comatose and aspirate saliva, that becomes a problem, because in that case, they're not then able to cough up. So they have the higher potential of developing lung abscesses, necrotizing pneumonia and empyema. And this is all from normal flora causing that disease. Now, the lower respiratory tract is usually sterile, may not be absolutely, but even if it has any bacteria, they'll be very small in number. And in the lower respiratory tract, the non-resident bacteria are limited by the mucus layer, traps the bacteria. There's also the ciliated epithelia, so it's able to brush out or wash out the any bacteria that settles there, and the presence of the alveolar macrophages, which you're going to more details of in immunology. So the alveolar macrophages would be able to take up or phagocytose any of the bacteria, and through various mechanisms be able to kill them, or using different mechanisms. Any breach in the lower respiratory tract would lead to the presence of transient bacteria, and that would lead to opportunistic infections. Then the GIT. The GIT, I think, currently is the most widely studied system in terms of the normal flora. And the normal flora varies based on the different parts of the GIT. The stomach is relatively sterile in most individuals due to the acidic pH that is found in the stomach. But as you move from the stomach distally, then you find that the pH increases, and therefore then the bacteria also, the normal flora also increases. In the duodenum, we have about 10 to the power of 3 to 10 to the power of 6 per gram of bacteria. In the jejunum, 10 to the 5 to 10 to the 8. Cecum and transverse colon, 10 to the 8, 10 to the 11. And as you get more distal in the sigmoid colon and the rectum, 10 to the power 11. And what is found mainly in the duodenum and the proximal ileum is the lactobacillus and enterococcus. In the colon, we have more of aerobic bacteria as well, tending to utilize the free oxygen that is found at that site, and this leads to anaerobic conditions. So you'll also find anaerobic bacteria in the colon. And though I said the stomach is sterile in most individuals, we have Helicobacter pylori, which has found in some individuals. And this has been shown to have an association with gastric ulcers and different types of gastric lung lymphomas. And this again will be talked about more in details later, once you get to the specific microorganisms. Okay, so there are various factors that influence the GIT tract. From this paper that was published this year, when the unborn, as we said, at birth, they're really relatively sterile. And then they get born, and the different colors show different types of microorganisms. So the purple or lavender is Firmicutes, the light blue is the Bacteroidetes, the dark blue is the Actinobacteria, the what color is that? Red, dark, mauve, depending on what color, whether you're colorblind or not, is Proteobacteria, and then the creamish beige is other bacteria. So if you look at this, you'll find that the breastfed compared to the formula fed look different, irrespective of what technique you're using for identification of your. With the DNA, they look similar, but the 16S tends to identify a wider range, and that shows a distinct difference between the breastfed, the formula fed, and the solid food fed. So the diet has been found to have the highest impact in terms of the normal flora, particularly of the gut. Antibiotic treatment actually has a very big effect on any microbiota or any normal flora, because when you give an antibiotic for a sore throat, the antibiotic does not know that it's only supposed to sort out the sore throat. It targets bacteria everywhere in your system. So in the gut, that shows a distinct difference between the healthy individual and the antibiotic treatment. But as in addition to that, depending also on the nutritional status of the individual, that will also cause quite a big difference. Whether one is healthy or one is obese also makes a big difference in terms of the components of the gut flora or the microbiota, as it is now more commonly known as, depending on the technique you use. And then there's the age factor, where the older you grow, the bigger the change. So this shows that, for example, the actinobacteria are much lower, between 65 and 80, but for those above 100, it takes quite a big chunk of the bacterial flora. So the composition is influenced by not just diet, but also age, antibiotic use, weight, race, geographical location, all seem to also have a role to play in terms of the bacterial flora. And of course, geographical location and race is also playing a part in terms of the diet that we're going to eat. So all those features have been found to have a role in determining what your profile of normal flora is, and especially the gut flora. Okay, so 1 second. Weight how? Weight how? I think it's not really known how the weight affects it, but what I is that your weight, number one, will influence your immune response, and that will also determine whether you're able to clear transient bacteria or not. At the same time, this weight is basically will sometimes be as a result of your diet. So diet again has a factor, a role to play in terms of your composition of your gut flora. Okay. What about health condition? Health condition, okay, health condition will affect your gut flora, yes, in several ways. What has been found is that the profile of particularly your gut flora, tends to depend on what health condition you're dealing with. So what you will find in a patient with diabetes is very different from what you'll find in a patient with another different condition. So, and I think that's something, because with the more current mechanisms or techniques that they're using for identification of normal flora, you're able to actually identify much more refined or more complete profile of what the normal flora has. Okay, for example, if you're doing normal flora using, for example, culture, you'll only be able to culture what you're able to culture, which is not everything. But when you're using genomics or study of the genes, then you're able to identify a much more varied profile and more complete. And I think that's still under study. So it's something that quite a number of people are studying currently. And I think going into details of not just looking at it in health, but looking at it in different disease conditions, different combinations of or more comorbidities where patients have more than one disease condition. Is the profile different? And whether what did I want to say? Whether if you're immunocompromised, if you're immune competent, does that profile stay the same? If you're different races living in different areas, for example, living in developing countries versus developed countries, it's been found to be different. But even within those regions, what they found, and this, what I'm talking about is mainly from, I think, studies done in the vaginal tract, is what they found is that people living in developing countries have a totally different profile from what is found in developed countries. But that even within developed countries or developing countries, the race also matters. So there are many factors that will come into play in terms of what your actual profile is and how it then determines or predisposes you to certain conditions. So all these are studies that are currently going on. There's a lot of material that if you're interested, you can read out there. When you're searching for it, search for microbiota, not normal flora. I think now they call it microbiota because it's much more detailed. Thank you for the questions. So if you have any questions, just throw it into the chat. I'll answer it as we go. So Maureen and Christopher, have I answered your questions? I hope so. Okay. So what's the most common drug you will ever prescribe apart from painkillers and probably painkillers? Is probably the antibiotics. And antibiotics, we know in developing countries, you can get them from anywhere. You can go to the pharmacy and buy whatever drug you want to use. You don't need a prescription for it. And unfortunately, as I said before, when you buy an antibiotic or when you take an antibiotic, it doesn't matter that it doesn't target your sore throat because it's an antibiotic. It's going to get into your bloodstream. It will go in and cause a lot of disruption of your normal flora, and that comes with consequences. One of them being antibiotic-associated diarrhea, where it just displaces, and we know that's one of the side effects of taking antibiotics. But the more dangerous ones are where you disrupt the normal flora, and in doing so, you allow a certain bacteria known as Clostridium difficile that you will talk about in more details. So you allow the Clostridium difficile to proliferate, and once it multiplies to such numbers that it's able to then cause disease, it causes diarrhea. Now, the only problem with C. diff is that if it's within a hospital setting, it spreads very fast. So most patients with C. difficile associated diarrhea will tend to be isolated. And when I talk isolation, of course, I'm not talking about isolation in Kenyatta National Hospital, in most hospitals in the country, because there's no space really. So that's one of the more, and difficile kills. So it's not, it's more of a bacteria that produces toxins and causes diarrhea. So controlling it can be quite a nightmare. The other condition caused by antibiotics is pseudomembranous colitis, and then there's also toxic megacolon. Whether that will stop you giving antibiotics, I'm not sure, but we'll learn by the end of the year whether it will. Okay, slides are not moving. Okay. I'll stop sharing and reshare because my slides are not moving. Okay. So then to the genitourinary tract. This, for the most part, tends to be sterile, apart from the last small, about a centimeter or so to the external environment. And this is only in health. So you will have that being sterile both in the bladder, in the ureters, and the renal pelvis, with scanty flora that may ascend from the perineum. The vagina itself tends to be very complex in terms of microbiota. At birth, the baby will tend to have a microbiota of normal flora profile similar to what's found in the mother. The neonate will tend to have a profile similar to what's found on the skin or what's found in the gut, but also have some strep, which could be from the skin. And that's mainly related to the pH, which also changes with the different ages. At puberty, it's more of lactobacillus. And the lactobacillus profile is, again, another field of study that's quite extensive currently, particularly with relation to HIV. And that's, again, something that you can search on and read about. Lactobacilli tends to keep the pH of the vagina in an acidic state, and that sort of tends to suppress. And once you disrupt this with antibiotics, that's when you find patients getting fungal infections, particularly yeast infections, Candida albicans, and similar pathogens. At puberty, apart from lactobacillus, we also have profiles similar to that found on the skin, some anaerobes in some people, and some strepts. And then at menopause, it tends to revert to the flora before puberty, again, because there are different hormonal profiles at these different ages, and that has been found, the hormonal profile has been found to also contribute to the kind or the profile of normal flora that you have, particularly in the vagina. So various factors will modify the vaginal microbiota. These will include age, as I've said. At childhood, they have low estrogen and glycogen levels. Their vaginal epithelium is thin. They have low lactobacillus species, and their pH is quite high. In adult women, the estrogen and glycogen levels are high. The vaginal epithelium is thick, and they have high lactobacillus, which leads to a low pH or acidic pH. Postmenopausal sort of reverts, similar to what's found in the prepubertal or the childhood age, where they have low estrogen and glycogen levels, thin vaginal epithelium, but it's also disrupted, and then low lactobacillus and therefore high pH. Pregnancy usually also changes the vaginal microbiota because of the hormonal profile or changes that the pregnant woman goes through. There's a lower concentration of especially mycoplasma and ureaplasma. There's a low pH, and of course, there's an increase in vaginal secretions. Then we have the presence of a disrupted microflora, especially because of infections, where we have vaginitis. Then you'll have Staph aureus and E. coli being probably the more predominant microorganisms. And where you have vaginosis, where the pH is acidic, then you have Gardnerella vaginalis and Mobilanca species being the more predominant organisms. Others, as I mentioned, are the ethnic groups, and these have been found in various studies, and again, they're out there in journals. So if that's an area of interest you'd like to look upon or research on, it's an interesting field. Smoking, because of its interaction of the hormonal profile, tends to also affect the vaginal microbiota. And then cancers, particularly cancers in the genitourinary tract, will also affect the profile of the normal flora that you find at that site. Okay, so all these areas have bacteria on site after birth. But then the blood is sterile, body fluids are supposed to be sterile, and tissues are supposed to be sterile. And why do we need to know that? So you'll see a patient, you take a blood sample, it comes back with a growth of whatever microorganisms. Now, decisions are usually based on what the normal is. So the lab first has to decide if when you're taking a blood sample, you're injecting through the skin. You're supposed to clean the skin well. If you do not disinfect the skin well, that means you're pushing normal flora from the skin into your sample. So the lab first has to decide, is this a contamination? Is this a true picture of what I'm finding on culture of the organisms? But even you as a clinician, when you get your blood bacterial culture results, you also have to then recall what did I expect to find? What is it a contamination? Is it a real picture of an infection? Because all that is supposed to determine what antibiotics or what treatment you give the patient. So when we get to clinical microbiology, we'll take you through all this in terms of how to take a blood, a sample, a good quality sample that will give you a true picture of what infection the patient has, and therefore make a decision in terms of clinical management. So knowing what is sterile is important, but also knowing what is normal flora at different sites also is important, because when you're getting body fluids, when you're getting blood and tissues, you're going through other surfaces that could contaminate your potential sample. So what do normal flora do? This is a very short lecture, will be done in the next few minutes. The first thing they do is have an exclusionary effect where the normal flora, as I said before, binds to specific receptors in the site which they occupy, and therefore they prevent bacteria that would otherwise cause disease at that site from binding. So they are competing with pathogens for not just the receptor, but also for nutrients that are needed for their own survival. At the same time, the normal flora would produce antibacterial substances. So, and as we go to specific microorganisms, we'll mention the specific substances that are produced by bacteria to kill other bacteria. So this is known as colonization resistance. So preventing colonization by other bacteria, whether transient bacteria and transient, we said, are both pathogenic and non-pathogenic. The normal flora is also important in priming the immune system. So the fact that its presence, number one, will stimulate the immune system to mature, but also its function. So they act as being able to induce or stimulate the immune system to be able to be functional, so that when you then get an actual infection, the immune system doesn't actually start from zero. There is some kind of surveillance already going on, surveillance of the body in terms of presence or absence of bacteria. they also have a nutritional function, and particularly the intestinal bacteria have been found to be important in synthesis and excretion of vitamin K, vitamin B12, and other vitamin Bs. And as I said, opportunistic infection, and this is something that you'll meet very commonly. And this is where you find bacteria are displaced from their niche to a site where they're not commonly found as normal flora. And this can be through an abrasion, any breach of the skin or mucosal barrier. For example, if someone stabs a person in the stomach, and they penetrate the intestines, then the bacteria that are found normally in the intestines will move into the peritoneum. And once they are, then they're in the wrong place, and therefore they have the potential cause disease. So that would cause peritonitis or intra-abdominal abscesses. There are many examples of this, more commonly in immunocompromised individuals, because they're not, with immunocompromised individuals, you'll find even a small cut on the skin, Staph aureus will get through the breach and cause wound infection, an abscess, or anything else. And that, anyway, these are things you'll see very commonly in the next few years. So the common bacteria that cause opportunistic infections, and this is not an absolute list, is Staph aureus, strep mutans, Enterococcus faecalis, strep pneumoniae, and Pseudomonas aeruginosa, amongst many others. Okay, so just a summary, and this is taken from a publication that was submitted last year. So the gut microbiome, I said, was the most widely studied normal flora, has positive effects. So this sort of summarizes basic role in digestion, supplies nutrients and xenobiotic degradation, helps in immune systems maturation and function, seems to have a role in brain development. There's something known as the gut-brain axis. And again, if you're interested, that's something that you can find in papers online. And then there's protection and clearance from pathogen invasion. Negative effects, particularly of the gut flora, is gastrointestinal disorders. IBD is very common, ulcerative colitis, Crohn's disease, and how can I forget what IBD means? Irritable bowel disease, sorry about that. Colon cancer development, it's been associated with metabolic syndromes such as diabetes and obesity. And this again has been shown to have different profiles that sort of drive the patient to have a predisposition to these conditions. And then has also been shown to contribute to chronic kidney disease. Okay, so let's say, for example, you've taken antibiotics or for patients who have Clostridium difficile associated diarrhea, and there are patients who will have the diarrhea for so long because their normal flora is not able to reestablish itself because they've been on antibiotics for a long time. For example, patients on endocarditis will take antibiotics for several weeks. So you're basically clearing or killing out all the good flora. How do you then go about promoting the good flora? The first one tends to be a bit yucky, but yeah, it happens. So what happens in fecal transplantation is where they take from a healthy donor, they take the stool and then take that and harvest the normal flora from it. Second, I'll get there. Oh, thanks, Maureen. We'll get there. So they take the fecal transplant donor sample and transplant it into the intestines of a patient with C. diff infection. So you're not taking the feces and putting them there. What they do is they convert them into tablets or capsules, and then the patient is able to take that. And it's been shown to then displace the C. diff and restore the healthy microbiome. And that has been shown to restore the patient back to health, particularly in patients who have repeated C. difficile infections, and therefore they're always having diarrhea. And the antibiotics that you give them for the diarrhea is probably aggravating the displacement of the normal flora. Therefore, you can use poop, as they call it, poop from healthy donors to reestablish the poop from the sick patient and restore their microbiome. So as Maureen said, and again, my laptop is refusing to move forward. So back we go, stop sharing. So as Maureen said, we have the probiotics, but then there's also the prebiotics. So probiotics are basically oral administration of microorganisms that are living to promote health. And what's the most common probiotic, you know? You can go onto the chat and just put a few. Nobody? What's the most common probiotic, you know? Yogurt, yogurt, yogurt. Anyone with anything else? Thank you. Anyone with anything else aside from yogurt? Mala, Flora? Anyone else? Femi, Flora, Avalife. Oh my God. Okay. Cheese, yes. When we get to 10, I'll stop asking. Yogurt, yogurt. I think we're already at 10. Flora from Floranum, cranberries. Okay, thank you. So this, and what do you look, okay, I think most people said yogurt. What do you look for in the yogurt to show you that it's a probiotic? Enterogamina, jamina. Thank you. What do you look for in your, yes, Yasin? Yasin, you have a question? Yasin, you have a raised hand. Okay. So fermented porridge, and someone said they're very expensive. Well, yes, they are, but if let's assume cash is not a problem, what would you look for? Do you ever look at them to see what you should be looking for? Does anyone lactic acid? Maybe. What specific will you be looking for on the pack of your yogurt? Lactobacilli, and Strep thermophilus. So again, they say some of the culture, they actually call them, I think it's written culturable bacteria or something. But the next time you go to the supermarket or any shop, just look at those packages. And maybe the next lecture that I give, we can have a 5-minute chat about that. If you remind me, that is, or take pictures and we'll talk about that. Thank you for participating. So what they are thought to do is to compete with other bacteria, as we said, displacement of the pathogenic bacteria, culturable forming units, true. Thank you. And then they also are able to stimulate a non-specific immune response, is what they are thought to do. I don't think it's been ever fully confirmed, but at the same time, you know that you could have a lot of fake culturable or fake yogurts that are written culturable, so you're not really sure whether you're taking any bacteria in it or it's just the yogurt. Anyway, but we also have prebiotics, and these are foods that have been found to stimulate the growth of the normal flora in the gut. And this is mainly the bifidobacteria and lactobacillus bacteria. And this also sort of provide nourishment for the normal gut flora. I thought this would be something that makes the sort of, every time I took for too long on a slide, it hangs. Anyway, let's go back to sharing. So this may sort of remind you which is which. So with the probiotics, they're live organisms. They could be bacteria or yeast. They're found in several types of foods that contain live cultures. That's yogurt, kefir, coconut water, cheese, kombucha, I think has become quite popular, kimchi as well. And some people say that they actually are very good for treatment of diarrhea, IBD, and other intestinal conditions. So any of those, as long as you're sure that they contain actual culturable bacteria. And then we have the prebiotics, which we said are foods, specific foods that nourish the bacteria found in the gut. And this would be garlic, wheat bran, bananas, and asparagus, and onions, and leeks, and all the others. So in summary, we've said that normal microbial flora is a population of microorganisms that inhabit the skin and mucous membranes of healthy individuals, not sick individuals. What's found in sick individuals is very specific to sick individuals, and that they can be resident, that's fixed type of microorganisms found at a specific body site, and it differs from site to site and differs sometimes with age, with gender, with race, and all that, and can also be transient, and these are temporary microorganisms at a body site, and that they could play a protective role, which we've specified which roles, but they also have the ability to cause disease. Thank you. Any questions? And you can have the rest of the 1 hour off. Any questions? But I'll pay back that 1 hour the next strap to a long leg. So I'll pay back. Any questions? Oh, there's a question. Okay, is the normal flora that a child has strictly dependent on whether or not what they've encountered it in the environment? It depends on what age are we talking about? Bajaba? You can unmute yourself and just ask. In general, okay, so with children, it depends on what age. So in general, once, let's say they've been born, then in the newborn, it will establish itself both mainly from what they come into contact with as they pass through the environment, the vaginal tract, and that establishes itself within hours. But then remember, post that, they're also coming into contact with the environment. And the environment is not just the ground. It could be the clothes they're wearing, diapers, could be the children who lick soil from the ground or poop from the cat will also acquire bacteria from that. So it's not entirely from the environment, but there's also the diet, whether they are feeding on breast milk or feeding on bottle or feeding on solids. So it's the environment is not just the outer environment. It's anything that they come into contact with, anything they are inhaling or ingesting or contact on the skin. Did I answer your question? Thank you. Any other questions? If you have any questions, you can always contact me. I'll be willing to respond. Thank you very much.